Hi, my name is Mervyn Singer. I'm at University College London, and I'd like to discuss with you the use of CPAP in COVID-19. Is it a good or a bad idea? I'll hopefully persuade you it's a good idea. And as you can see, half of the UK's sickest patients were kept off ventilators. Conflict of interest, I was involved in the development of a CPAP device, which was a sort of humanitarian endeavour, open access worldwide. So, what are the pros of using CPAP in COVID-19? Well, clearly, we're all familiar with CPAP. It does improve oxygenation in patients with respiratory failure. Clearly, with the huge influx of patients, there was a lack of ventilators, a lack of intensive care beds, and CPAP is much easier to manage than a ventilator if the staff are limited and inexperienced. And we all recognize with ventilation that there is VILI, ventilator induced lung injury, and other complications that arise. On the other hand, what are the cons? Well, there were fears about an increased risk of viral transmission to healthcare workers, potential harm to the patient if there's a delay in intubation and ventilation, a theoretical risk of so called SILI, spontaneous breathing induced lung injury. So, very large tidal volumes, spontaneous breaths, high transpulmonary pressures causing lung trauma. And some CPAP devices are oxygen hungry, and that could potentially compromise the hospital oxygen supply. However, to paraphrase Franklin Roosevelt, the only thing we have to fear is fear itself. When COVID broke out, advice here from the American Society of Anesthesiologists was it may be prudent to proceed directly to endotracheal intubation because non-invasive ventilation may increase the risk of infectious transmission. The Australian guidelines recommended high-flow nasal oxygen, but didn't recommend non-invasive ventilation, and they recommended that deteriorating patients should be considered for early endotracheal intubation and invasive mechanical ventilation. And certainly that was the initial advice in the UK on the 16th of March, where, as opposed to the Australian advice here, it was to avoid high-flow nasal oxygen, but only use CPAP in the short term as a bridge to intubation. So that was the climate around the world. However, when you read the literature, we wrote a letter about this. There was this nice paper in anesthesiology actually challenging the evidence. Just a quote from the Greenland paper, concern that use of non-invasive ventilation or high-flow nasal cannulae specifically leads to worse environmental contamination is not substantiated by current available evidence. And there was this nice paper in JAMA, just somebody coughing, so they could be wearing a face mask and coughing violently, and the viral particles can go up to 7 to 8 meters. So again, there was this fear, but it wasn't actually substantiated by the evidence or the experiences in China and in Italy. There was this worry about SILI. It's largely a theoretical concern. There's a bit of suggestive animal data, but there isn't any strong human evidence. A lot of it is secondary evidence. And this was talked about by John Marini and Luciano Gattinoni. However, people were challenging the notion of putting people early on ventilators. The ventilator could cause harm. And this nice article from Martin Tobin and colleagues made the point that even if high tidal volumes and patient-induced spontaneous breathing-induced lung injury could play some role in the progression of respiratory failure in COVID, for which there is no convincing evidence, this does not justify the liberal use of endotracheal intubation, for which there are decades of research documenting fatal complications. And what was actually happening in China and Italy? Du Bin, who's one of the leading lights of Chinese intensive care, who'd been sent by Beijing to coordinate the critical care response in Wuhan, said, yes, there may be a high failure rate, but then there's also a success rate as well, and delayed intubation may be detrimental to the patient. However, he pointed out that with the huge surge of patients, there weren't the resources to intubate and ventilate everybody. Italy, again, we were seeing pictures in the UK media of Italy in hell, Britain in weeks, but you can see they were using here helmet CPAP. And I made contact with lots of friends and colleagues around Italy. Guido Bertolini, who was one of the leaders of the emergency department response team in Lombardy, said to me, I haven't got any hard data, but I'm absolutely sure CPAP is the answer. Here are the Ligurian guidelines, courtesy of Paolo Pelosi, and you can see CPAP featured strongly. And personal communications with about 10 intensivists around Italy suggested that many patients could be kept off ventilators. There weren't reports of healthcare workers looking after these patients who were wearing PPE, developing severe COVID infection, and no problems with their hospital oxygen supply. So we, therefore, against the then national guidance, adopted CPAP as part of our early strategy. And there was strong buy-in from doctors, nurses, and our hospital management. So we developed a clinical algorithm commencing at the front door of the hospital. We started training up doctors and nurses to manage CPAP in non-ICU areas. And a talk I gave earlier was about this development and manufacture of a CPAP device. This is the algorithm we used, and when the patients came in, they had an oxygen challenge to see how they responded. Depending on the response, they either went to early intubation, could stay on CPAP, or just remain on an oxygen mask or high flow nasal oxygen, and obviously be continually reviewed. We launched this on the 20th of March, just as COVID was hitting London. Here's the device we developed, which was a copy of an old device from 1992. This was an exact replica, and we got approval for it on the 27th of March, and we improved on the oxygen efficiency by up to 70%, and that was approved on the 2nd of April. And with Mercedes, who are our partners, we made 10,000 devices by the 15th of April. The UK critical care community realised that CPAP was a good idea, and national guidance was changed on the 26th of March to say that CPAP was the preferred form of non-invasive ventilatory support for COVID. However, reasonably, you had to monitor the patients. If they weren't coping, if they weren't tolerating the CPAP, if they were struggling, you shouldn't delay intubation in those patients. The UK Intensive Care Society, the faculty, also highlighted the fact that CPAP may be of benefit early on in the disease process, and they may not need to be intubated. And that came out on the 28th of March. Has it made a difference? Last few minutes. Well, there's no randomized control trial data. Our experience at UCH, which other hospitals, certainly in the UK, have mirrored, that a large number of our patients, so the hospital through the front door in the emergency department admitted 468 patients, a quarter of whom got CPAP. 45 had, of these 124, had CPAP as a ceiling of treatment. They weren't suitable for intubation and ventilation. A quarter of these people, who are generally more elderly, frail, with comorbidities, survived to leave hospital. Of the 79 who had full escalation, 47 were eventually intubated, and the overall survival of these 79 patients was 73%. Because it preserved our ventilator capacity, we could help other hospitals, so we actually took 44 ventilated patients to help out other places. I'll just show you some figures on our ICU data, so not patients on the ward. 93 patients were admitted for initial CPAP therapy. Success, in other words, they survived hospital without the need for ventilation, was over a third. And by failure, either they died if CPAP was a ceiling of care, or they needed invasive ventilation, some of whom lived, some who went on to die. When we looked at the initial respiratory parameters, again, many of the patients who got to intensive care were on a lot of oxygen, 80%. Their respiratory rate was about 33 on average, and the PF ratio the median value was about 13. So that was on the borderline between moderate and severe respiratory failure. But looking at those who eventually managed well with CPAP or didn't, you can see there was no difference in these parameters. The patients who succeeded did improve over the next 4 to 6 hours. However, when you look at inflammatory markers, biological markers, you do see a difference. So those that went on to fail, die as a ceiling of care, or need intubation had much higher values of C-reactive protein as a marker of inflammation. They had much higher values of D-dimers as a marker of fibrinolysis, which probably suggests more thrombus, macro and microthrombi formation in the lungs especially, and a much higher values of NT-proBNP, in other words, ventricular dysfunction, and echoes showed again a lot of right heart strain in these patients, perhaps reflecting a greater degree of pulmonary emboli and thrombi. So you can see that the patients who did well on CPAP had a lesser degree of this sort of thromboinflammatory milieu picture. What happened to these patients? Well, the 32 who managed well on CPAP all left hospital alive, didn't need any other organ support. But those who needed ventilation, many needed vasopressors, many needed renal replacement therapy. Could this other organ support be related to an increased thromboinflammatory status and right heart strain that I was talking about earlier? But is there an iatrogenic component because of the need for ventilation? Many of these patients needed quite heavy sedation. Try our best, but some of these patients did have high airway pressures, and to try and protect the lungs, they were generally being kept on the dry side. So all of these features may have contributed to impaired renal function and cardiovascular function. Coming to the end, what randomized control trials should be done? I think there is a need. Clearly, we need scientific evidence. Should we compare CPAP or high flow against early intubation? I personally don't think that's the right question. Why expose patients to the risk of villi and the complications of sedation, nosocomial infection, and so forth if it's avoidable? And also, if you are stretched in terms of resource, why use precious intensive care resource? Perhaps the interesting trial is to do early versus late CPAP. Would early CPAP ameliorate the progression of inflammation and lung deterioration? So in summary, CPAP allows many COVID patients to avoid ventilation. Yes, you need to identify the patients who aren't coping with CPAP, increase work of breathing, struggling, and intubate those patients if appropriate. Does it make a difference? Don't know for sure, but I'm sure many other places who've used it say the same. It definitely spares resources in intensive care, and I think it does have a place for patients who have a ceiling of care that doesn't include invasive ventilation. Thank you very much for listening.